afternoon, everybody. Welcome. This is our panel on healthcare economics and policy. I'm Elizabeth Kuhn from St. Mary's Regional Medical Center in Lewiston, a member of our planning committee. I'm really delighted to welcome all of you today. We have a great panel who will review some of the exciting things happening nationally and locally related to this. And then we're going to leave a good amount of time in the second half for questions and answers and to hear what's happening locally in your programs as well. So our panelists today include Steve D'Amato. Steve was with New England Cancer Specialists for more than 35 years and established their pharmacy program, became executive director. He has extensive knowledge in electronic health records, drug utilization, value-based care, and practice management. And he also was a founding partner of, am I going to say it correctly, Ciencia Pharmacy Advisors. And he serves on the Maine State Palliative Care and Advisory Council. And then Dr. Vance Brown spent most of his career as a primary care provider. He's dually certified in family and internal medicine, and if that wasn't enough, then went back to become board certified in hospice and palliative medicine. He has served at, I believe, Cleveland Clinic, is that right, Vance? Cleveland Clinic, was CEO of Bassett Health, and is now serving as Chief Medical Officer at Androscoggin Home Health Care and Hospice. And then Olivia Alford is the Director of Delivery System Reform for the Office of Maine Care in the state of Maine. And she provides consultation and expertise regarding the design of systems for increased accountability to ensure the delivery of care of high value for Maine Care members. And she focuses on everything from delivery reform related to primary care, hospital reform, behavioral services, substance use. So she's a wealth of knowledge as well. So the format will be that each of the panelists will have time to share some of their insights and expertise with you. And then, as I said, we'll have plenty of time for answers in the second half. With our slides, here are the learning objectives for today. We hope that we're going to be talking about how to incorporate an integrative palliative care program in a clinical practice setting. We also want to describe the benefits of an integrative palliative care program for patients, providers, and the healthcare system. And then finally, to illustrate opportunities to incorporate palliative care into healthcare reform efforts. None of us have anything to disclose with conflicts of interest or financial. So with that, I'm going to turn it over to Steve for this first section.
Thank you. Good afternoon, everyone. It's great to be here, and the listening session last night was very moving for me, and you're going to see repetitions of what was said at the listening session last night on some of the slides you'll see as you move forward. Just to give a little background, I'm a pharmacist by training. My career started as a pharmacist at Maine Medical Center. I established their oncology program back in the late 70s, early 80s. Then I moved over to the private practice side at New England Cancer Specialists and set up their pharmacy program and so forth there. And self-educated myself and eventually became their executive director over time. I've always been involved with hospice and palliative care. Pain management is one of my passions. That's what I've always done throughout my whole career and worked with Candy Powell and others throughout the state with that. So I understood the value of palliative care in the community setting. So when I took over as executive director at New England Cancer Specialists, one of my missions was to establish a palliative care program within that practice. And we accomplished that. We hired a palliative care physician. We had advanced practice nurses who were certified in palliative care, along with the nursing staff that could support them, and a pharmacy staff that could support them, as well as clinicians in the clinic. And the benefit of that, you all know, I'm speaking to the choir here, but it was a comprehensive multidisciplinary care team that can provide patients with the highest quality of care and provide value to a lot of stakeholders. So in my role, I also understood that moving forward, contracting in a value-based world, that you need to be able to demonstrate the value of those programs. And so we embarked on a CMMI project called the Oncology Care Model. And palliative care was actually a big part of that. And so practices across the country struggled, to set up internal systems to deliver palliative care because they were being measured really on treatment in the last 14 days of life, which was a huge cost expense for the system, as we all know. So that was one of the measurements in the OCM that we were held against, and our practice was, outstanding in that regard because we had a palliative care program. But we need that. But today, patients are living longer, and with chronic diseases and with the treatments that are out there now are very, very costly. You all know that when you look at the financial difficulties, the financial toxicities patients have when they try to get their medications. That's one thing I was proud of at our clinic as well. We had financial advocates and a foundation to help patients with access. But having an integrated team that understands that is really critical to keep costs down throughout the continuum of care. So what we did is we embedded the clinic right into the clinical clinic. So palliative care could have joint visits with the clinical team. We found that to be a little burdensome from a time perspective, and so what we did is we created a different space altogether. We heard that patients really didn't like coming into the medical clinic itself, but if they had a different space where they could see their palliative care team, they would prefer that. So we rented another space and retrofitted it to be more welcoming to the palliative care patients and their team. So we did that as well. And palliative care, as I mentioned, is a large focus of value-based care programs today, and we'll see what happens with the enhancing oncology model, which is the new version of OCM, where the applications are actually due for that program on the 10th of this month. So what were the challenges that we had? What challenges do you have in general when you try to institute a palliative care program? And we heard this through the listening session. We've heard it multiple times. Inconsistent definition and understanding of what palliative care is. The limited benefits to the patient, family, payer, and health system, and confusion about the essentials of effective palliative care program. So we heard from our colleagues in Jackman where resources are more constrained. They don't have the resources we might have down here in Southern Maine. And so whatever staff that you can, enlist, bring on board, train, help them to learn about palliative care and help patients in that community, anything that you can do works. So you don't always need to have that gold star team, so to speak, in place to deliver palliative care. And as we know, weak reimbursement for palliative care is a huge problem and something that we need to address systemically. The benefits you all know, not to spend a lot of time here, this is the things you all know, but really decision-making, putting the patient's goals first is one of the biggest things about palliative care. I think what I learned at a different conference, not a palliative care conference, but when you really sit with patients and explain what's really going on in a simplistic fashion with simplistic stick diagrams, for example, on a patient's disease state and where they're headed, sometimes they have a completely different outlook on where they want to go with their treatment and their decisions. So really having those conversations is very important to really make sure that we fulfill the patient's goals and desires, along with supporting the patient and family. Again, the navigation that goes with that from a multidisciplinary team, certainly we know it improves quality of life, pain and symptom control, focus on mind, body, and spirit. We heard that today as well. And certainly reducing unnecessary hospital visits and trips to the ICU. Vance is going to talk a lot more about finance and we'll dovetail into that. But some basic numbers, if you look at the financial impact of integrated palliative care programs, if you look at hospital costs per day of the palliative care program, you can see the numbers on how much it helps within the system to decrease costs, whether it's average, cancer, or a patient with 4+ diagnoses. In the home setting, there are also savings to be realized. Just one study looking at this, and this study looked at 506 patients, and they looked at the overall medical costs at 396 patients in the palliative care group, and they showed gross savings of $24,643 per member per year, which was almost a 70% decrease in cost compared to the control group. And if you go to the literature, you'll find repetitive articles that really discuss the efficacy of palliative care in relation to the financial impact on various stakeholders. So where do those cost savings come? From integrated multidisciplinary programs. Pharmacy is a huge one. When you look at the cost, Dr. Van Kirk mentioned methadone. I was a huge proponent of methadone in our practice and educated our physicians on that. It's dirt cheap, compared to brand name opioids, sustained release opioids, and so forth. And patients have limited resources, and that's a great way to get a great medication to them at a low cost. Laboratory tests that don't need to be done, procedures that don't need to be done. We talked about the ER and hospital utilization. All of those things will lower the total cost of care and certainly decrease length of stay when you look at hospitalizations, 43% fewer overall days and 33% fewer days in the ICU. So we know that palliative care programs can reduce costs across the whole continuum of care for the patient. And so with that, we will go to Vance, Dr. Brown.
I'm going to follow Steve in parallel comments, just to make a couple of quick comments about myself. Quite a few years ago, it seems like an alternative universe, I was a chief medical officer for a health system, and we were applying for the Pioneer ACO application, and there was this dreaded question on there. Everything was about a half a page answer, and then there was question 27. Please describe in 4 pages or less what you're going to do to improve the lives, the quality of care that you are going to provide to these Medicare beneficiaries, and how you're going to cut cost. Like, you know, that's not a, you know, really simple question, right? And, you know, at the time we focused a lot on, if I use the term small practice area variation around some of this stuff. And to be honest with you, the ACO, following that philosophy, was kind of successful initially. I started reading more about, I'd been interested in hospice and palliative medicine for a really long period of time, but kind of was in an interesting place. I did have the opportunity to, miss the opportunity to grandfather into it and a few other things that led me here. But I started doing more reading, and eventually we started to change a little bit around some of the system initiatives related to try and build more awareness of hospice and palliative care overall. So I originally started this to kind of give you some, you know, what was I reading? You know, why did we start thinking about some of this stuff? Some of this literature is pretty well known to you. So palliative care seems to decrease costs and may improve life expectancy. So there's not a lot of data about the improvement in life expectancy, but there have been a couple of seminal articles published that actually, you know, palliating patients' symptoms and challenges may actually extend their lives rather than shorten it, contrary to popular belief. The receipt of palliative care in hospital settings decreases acute care costs. There's a huge amount of literature surrounding that, more for cancer patients perhaps than the general population. And the more comorbidities you have, the more cost effective it is in terms of reducing costs. The receipt of palliative care for non-cancer diagnosis, well established to decrease ER utilization, less hospitalizations, some of the things that Steve talked about, modestly lower symptom burden overall, and that study didn't really show any real significant difference in quality of life scores. And then palliative care practitioners, and I think this is really, really important. Palliative care has been invaluable throughout the pandemic, right? And, you know, there have been articles that are starting to appear, be published on this about how that extra wraparound layer of support for teams in the hospital who, you know, oftentimes were just running, you know, running ragged, I guess would be the right way to say it, were assisted, and many of those key conversations actually occurred with through the benefit of having palliative teams in place. All right. There's one of the things that's really important. I mean, I think if you've seen one model of palliative care, you've seen one model. And I think there's a lot of very effective models out there, some of which feature a social work model, some of them a nursing model, some of them social worker and nurses together, some of them physician. I mean, the work is largely common overall, and some of it is dependent on available resources and how you can make things work overall. I mentioned palliative consultation with the nurse social worker model seems to decrease community, in a community setting, reduces total medicine costs, ICU admissions, hospital admissions, et cetera. And then there's an emerging body of evidence, and I'm going to just mention this because I'm very interested in this personally, that you can prospectively identify those patients who are at risk for poor short-term outcomes and high spend, and using artificial intelligence and try and get them enrolled in palliative care earlier. We've been very interested in this organizationally. Our organization has about 1,500 people who are in home health at any one time. And while not all of those patients are candidates for palliative care or hospice, they're on the continuum, right? Some of those folks in the Venn diagram would be high risk. You can run those folks through an algorithm to figure out which patients might be good candidates for palliative medicine, which is something we've been doing for a little while now. So I showed you all this data, or all these studies, but I want to talk about some local data, because this is actually like where it's at, right? Can we show this in our own local experience? So we use a data vendor that actually is able to look backwards and forwards in time, pre and post enrollment in palliative care. This is not an experimental design or a randomized study or anything that we don't have the capacity to do. We have about 325 patients who are following longitudinally in palliative medicine right now in a community setting. Our model, I'm not here to defend it as being superior or inferior, but it's basically a model where we have either a nurse practitioner or physician see those patients either by virtual health, in-home, or and increasingly in clinic type settings. And then we have a lot of longitudinal follow-up provided by our nurse, and we're increasingly trying to utilize social workers to help us in some of the issues related to mental health and other challenges along those lines, which is worth a long discussion. So I'm not here to say that's the definitive model, that's just what we're doing right now. In this data, so you're gonna say, well, where are all the patients? You just told me you had 325 patients. We ran all 325 patients. Of that group, there were some exclusions, okay? And so the exclusions were, they had to be Medicare only, because that's the only data we can get. So they might be Medicare, but if they have a Medicare intermediate, a Medicare Advantage, for instance, we don't have access to their data. The insurance company has that. And we wanted to make sure we had access for all periods of time that these folks were enrolled in our palliative care program. We also don't tend to hold on to these patients indefinitely. We've got so many referrals going now that we look for, symptom relief. We look for meeting goals of care and getting some of those issues established as we go. So with all those caveats, we had 88 pure Medicare patients who we were able to look back 3 months and forward 3 months, which is, a sizable number. We're starting to get to some statistical significance here. So you'll see the points that Steve was making about, spend. This is a significant amount of spend in these folks overall. So that the onset was involved. We declared our start date was the first telephone contact with the patient. Okay. So that's important because it does, it might even be more powerful if we said our contact was the first date of consultation. We define it as that. So if you look at this pre-spend and post-spend for this large group, you can see a pretty significant, almost $400,000 savings between those 2 periods of time in the 3-month interval. That's a 26% decrease in total cost. And, the huge spend $17,000 for that group down to $12,000 on an individual basis. When you look at 6 months, the trends are really durable. And you see, huge decreases in spend, global spend for these patients as well. By the time you go out 20 months, go out 12 months on either side, you start to see that fall off, and we haven't done sort of if I use the term, an analysis of that variance to figure out how much of that may be driven by 1 or 2, really expensive patients. You can see the number of patients falling because of the natural fall off. The other thing I would ask you to think about, while I believe palliative medicine is a very powerful intervention, when you think about the natural history of a patient who goes back 12 months in time and you go 12 months forward, you're talking 2 years to the end of life with these patients who all have really life-threatening illness. Unintervened, we know that the curve goes like that.
Does that include all Medicare events, like surgeries or anything that happened in the Medicare spend?
Anything.
So all it would take is one huge
claims.
outlier.
Yeah.
It would take us one big one, yeah.
Right. So we haven't had a chance to do that. Everybody always talks about, well, let's see if we can, cut inpatient admissions. The data is really powerful here. 53% drop off in 3 months, 42% in 6 months. And at 12 months, again, just a slight uptick, which I think is probably way less than what you'd expect. And then same thing in ED visits. This is about trying to prevent people from going to the emergency room. Any given day, if one of these patients goes to the emergency room, they could get admitted. They have a urinary tract infection or something it could happen any single day. Again, huge changes in ED utilization, and also observations were included in the ED group as well. So 38%, 15% drop off, and again, at 12 months, you're seeing it kind of normalize and maybe increase a little bit.
Hey Vance, can I ask a question really quick?
Yeah, please. Sure.
How did you consider patients who went onto hospice during that time? Did they fall out of your sample, or were they?
No, they were included in that sample because if they used a hospice benefit, Medicare hospice benefit.
Yeah, okay. Just that's such a powerful way of
Yeah.
not using the ER.
I approached this discussion really from a palliative consultation thing. Everyone in this room will recognize that hospice is part of palliative medicine, right? And the literature is, there's telephone books worth of literature supporting the cost effectiveness of hospice. That's why for one way or the other, the federal government loves Medicare, loves hospice. It's really cost effective compared to the alternative trajectory overall.
So Vance, in that 12-month one, is that including the expenditures for hospice care? Huh. And it went up?
Yeah, but
slightly.
again, many of these, you saw the numbers falling in part because a lot of these patients are dying. Yeah, hospice, no hospice. Just the nature of the population, overall. So I'm going to transition just for a second, but I want to sort of set up a discussion, hopefully for Olivia, which is, this is one person's, view of, what are some of the barriers we've got to overcome, workforce, primary workforce, and especially, care workforce issues. The lack of aligned fiscal incentives is huge. So I was a hospital CEO for a while, and I'm going to just say something that sounds really brutal, but if you're a hospital CEO, you get paid to basically put butts in beds. That's just a fact. It's really hard, as much as philosophically I believed in this program or a program like this, it's really hard to kind of go, I want to invest a lot of money in something that basically will help assassinate my core business model. That's a fact. I'm just saying I've lived it from many different perspectives. Rural resources and provider care models, which we've talked about in other contexts. One of the things I think has been a big barrier is there's been really no readily available palliative quality data to demonstrate value. Many of you are aware now that that situation is changing now. Single national registry is coming on board, and hopefully we're going to be able to start to see that start to change overall. Payer momentum in Maine, with the exception of our colleagues, and Olivia will talk more about this, there hasn't necessarily been a lot of movement, and nobody's coming to us and saying, hey, how'd you like to actually do a capitated contract, in palliative medicine? I'm waiting for that, but not a lot of love around that so far. Reimbursement for Part B billing is really poor. Most of the time, you can't even imagine, the codes you need to submit in palliative medicine, there aren't codes for this. I spent 2.5 hours with this patient today running back and forth, 5 different encounters, Medicare didn't believe that that's possible, but it's the work of palliative medicine, as you're all aware of. The other thing that's challenging is the challenge of trying to aggregate patients for provider efficiency. We're building clinics and stuff like that, but these patients don't travel well. At any given time, many of them could be on a hospice program. Once you qualify for hospice, we roll to you, okay? You're not in hospice, we're like, hey, you come to us, or, that's a challenge. And then the payment for interdisciplinary work, which I think is so important. So we're really excited that our colleagues like Olivia and others at the state are working on trying to come up with a defined benefit. So I'll let her comment on that.
Can I ask a quick question? What's the single national registry that you referenced?
What's that?
The single national registry?
Oh, the PCQC?
Okay.
Yeah, yeah. Is everyone familiar with that? There's just quickly, there were 3 separate registries for palliative medicine quality data. The CAPC has basically spearheaded over the course of the last 2 to 3 years a change to drive to a single registry. It's really just kind of coming on board now. We've been submitting data now, but we don't yet have some of our comparison data as to where we are compared to peer organizations. I'd hope that most folks would start to submit to that so that we can all kind of compare some of the work that we're doing. So.
All right. Thank you so much for having me here today. And I have my colleague Heather Palliative. We're 2 of the people at the Office of Main Care Services working with all of you to develop a palliative care benefit for Main Care and the Main Care program in Maine. And it just really aligned with a lot of what Steve and Vance said. And you'll see themes here, but I also just want to acknowledge that I think Medicaid programs have this unique opportunity to do things unique to their locality that are innovative and that actually do spread across states and into other payers and into other markets. So I think, again, I know, so I firmly believe we will do a very good job with this effort here and that it will generate some good conversation for others as well. So I am the Director of Delivery System Reform, as mentioned, and why I bring that up is that palliative care, from what we've talked about all today, but really even from Vance and Steve, is really about delivery system reform. The framework for delivery system reform brings in concepts, and this is the federal government's framework, but it brings in concepts of accountability, quality, value, health equity, and cost, or affordability, whether it's taxpayers, the patient themselves, and then partnership. This isn't our framework in Main Care, but I firmly believe this is why palliative care fits so well with the work that we do in delivery system reform, is that there are a lot of moving parts and there are a lot of incentives at play, and there's a lot of ways to address or get to the outcomes we want to see. Main Care has been very committed to delivery system reform and payment reform. So when we talk about payment models, that's really one of the critical pieces of palliative care is how can we pay for what you're all doing so well? And how can we align the incentives so that what the hospital has for an incentive versus what palliative care providers might have for the incentive, they work together and they produce the overall outcomes we're looking for. So Main Care has, just to kind of level set, we have set a goal of having 40% of our reimbursement tied to alternative payment models or models of payment that link to value by the end of this year. And we are actually about just over 36% now. So a few more months, we'll reevaluate our 2022 data, and I think we'll have reached it, hopefully. I am fully on board. We are fully on board with the idea of palliative care fitting in the seriously ill continuum of care. I think from an insurance perspective, there's been so much investment in chronic care management. There's a lot of interest in hospice, very clear. The palliative care part of the continuum has been less clear. I think even at Main Care, when the initial legislation came through, which I'll talk about in a minute, to develop this benefit, we were confused. Do we cover that? Like, I thought we covered that. Do we not? Like, what are we not covering? So there was confusion. We certainly know that we cover chronic care management. We have a lot of models to support that. We certainly know we cover hospice. We weren't quite sure what we were missing. So it's been a learning experience. So there was a LD that passed last session to direct us to pay for palliative care services. We are very supportive of this effort. So this is one way to go about getting change done. But again, we were very supportive of this work regardless. The legislative directive says that we must cover interdisciplinary teams, regardless of setting, have quality control, and use national standards, as well as convene stakeholders, which we love to do. And Heather has spoken with many of you, and she's a resource for you to talk to one-on-one after if you'd like to have some more conversation about the stakeholder engagement. Generally, just quickly, this is our process as a payer to developing a new to us model. We have been working with national and local experts. We've been doing a number of stakeholder sessions. We usually end up hiring a vendor to develop the reimbursement. What is the rate that we would pay for these services? Not always, sometimes we can do it internally. And then we have to go through federal and state approval processes, which are really what you're all preparing for to make sure that we can pay for this legally. So I won't go over all of these. There are a number of themes that have come out of the stakeholder engagement so far, which this whole conference has touched on. I think that they're all just, again, supporting the fact that this needs to be an alternative payment model. There can't be the, how do I bill for 5 different visits that happen in the course of 24 hours versus something more flexible that accounts for the team that's working towards the goals, and let's assess whether the team met those goals, and let's pay for that. Those are the kinds of ways of thinking about payment models that come with alternative payment models. There's certainly issues that we have not resolved regarding rural and ultra-rural differences, which payment models always need to account for, as well as just broader system transformation that comes with consumer and provider awareness, which will be an ongoing effort. I just wanted to give a quick example of maybe what Vance teed up a little bit about the incentives and how important that is. So in this palliative care work, even though this new stakeholder work is new, we have a model for trying to create shared interests across providers to drive actual change in the healthcare system. My visual for this is like creating the wind for the sails. That's what it's supposed to be. So while we are doing this palliative care benefit, we are also doing things like including total cost of care metrics in our primary care models and in our accountable care organization models are built on total cost of care, palliative care, shown to decrease total cost of care. We even put a requirement in our new primary care model that requires, it's over 210 practices in Maine are part of this, and they are required to offer or refer to advanced care planning and palliative care consultation. That won't be something that just happens. It is a requirement, but that's something, again, that helps support the future work of having a palliative care benefit. And then we use our contracts to enforce these things in the various levels of the health systems in Maine. And we like to bring in, when possible, infrastructure and education to support that through other funding mechanisms. So I'm going to stop there. I think I wanted to make sure we have time for questions. We just, again, believe this is part of the quadruple aim of achieving better patient experience, lower cost, improved population health, and the quadruple aim, provider experience, health equity. I think you could count a lot of aims here, but we have been just thrilled with the commitment from the stakeholder groups. I have never seen stakeholders attend sessions as consistently and engage as much with us around this palliative care benefit. And so again, I encourage you to reach out to us some more, as we are not yet to the point of having a proposal. So we're still in the development stage. Okay, I'll turn it back to you, Elizabeth.
Thank you, Olivia, and thank you, colleagues. I'm going to invite our panelists now to just bring your chairs around to face everybody. And while that's happening, I just do want to acknowledge Margaret Craven, who is our representative from, I will proudly say, from Lewiston, who introduced legislation multiple times in Maine, actually, for palliative care, and to really thank Olivia, Heather, and our state colleagues for taking this to heart and really moving it forward. I just can't even tell you how excited we are about it. And it's garnered national attention as well, which is really exciting. So thank you. So we will open it now for your questions or to hear, what's happening in your, do you have a story to tell from your local area? The far back row, and then we'll come to the next one.
The panelists have mentioned a couple of times the challenges of workforce in palliative care, and I wonder if you happen to have any information, particularly you, in the current state of resident and fellowship training for young physicians in palliative care. Are there enough people in the pipeline? Are the trends good or bad? is there beginning to gel a professional society consensus as to how you should train a young physician?
I'll take a whack at that. Anybody in the room, feel free to correct me on this, because I may not have. So I think it's pretty easy to track the number of physicians that are in the pipeline, because there are 2 fellowships in the state, right? There's the Maine Med VA Fellowship that I believe has 3 fellows per year. Vanessa, you guys have 1? You have 2 fellows, okay, so that means we're training 5 physicians a year in this. I was concerned enough about this that I started talking to Jackie Fournier, one of our nurse practitioners who's an irresistible force, and Jackie, along with other NP colleagues, basically built an NP fellowship within our organization. Katie Friend, our first NP fellow, was here at the conference, and I think doing fantastically. One of the reasons that I was pretty keenly interested in the NP model is trying to think about our service area. So like many of you, we have there's Lewiston and Auburn, and then we get this massive rural service area. And, a lot of these folks do need visits in the home. Putting any sort of provider in a car is bad. Putting a doctor in a car and driving around, it's like financial suicide. I'm just telling you. So for it to be even remotely cost effective for physicians to do this work, the patients have to be highly aggregated. They can be economically successful in a hospice in a really busy, place like Maine Med or probably Eastern Maine, where you got tons of consults, you run around, boom, 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 boom. You can make a go of it. But in almost every other environment, physician labor model, I think is going to be really difficult to sustain in some of the rural and clinic models. And our nurse practitioner colleagues, I think, at least we've discovered, are fantastic at this work. The risk of sounding sycophantic or anything like that, nurses, they're natural patient advocates, right? Anybody with nursing school, has that hardwired into them. They're really fantastic at this work and very cost effective overall. I think the other piece that's really important to think about this from a provider power, piece of everything I just mentioned is really about specialty palliative medicine. If we're going to ever meet the gaps in this state, we've got to figure out how to deliver better primary palliative care overall. Our primary care physicians and nurse practitioners and PAs who are in the trenches, as well as oncologists and cardiologists and neurologists and others who actually take care of patients with chronic intractable illness, have to become progressively comfortable and progressively competent in managing some of the common issues that need to be addressed and palliated. So I think we're on the way for a state this size, and in terms of the provider manpower, but we've got a long ways to go. And I think much of the next, it's trying to figure out what the right mix is and trying to figure out how to, next dimension, I think, is how to train more people in primary palliative principles.
And one of the ways we're doing that is through Project ECHO for palliative care. So I wanted to make sure, is everybody aware of that wonderful program and resource we have here in Maine? So I see a couple heads maybe nodding no. So just very briefly, Project ECHO is a way to help primary care physicians become more comfortable and competent in some specialty type areas. And so through Maine Health, there is a palliative care Project ECHO, which has been running a few years now, started by the State Palliative Care and Quality of Life Advisory Council. The good thing about that is it's open to everyone in the state, not just Maine Health. It's open to primary palliative care teams too. So not just providers, but chaplains, social workers, pharmacists, et cetera. So if anybody is wanting that resource, I write it on the whiteboard later, but it's free. It gives you CMEs. I mean, it's an amazing resource. So yes, sir.
I was just going to point out something I think, and people can correct me if we're wrong, we've certainly shown with community-based palliative care that we get early referrals to hospice, and our hospice length of stay on average is longer, which is I don't like to think about the money of what we do, but it's a huge source of income for us. A couple other thoughts, as an MP in the field, I think we sometimes have to remind certain parts of the administration that, if you're going into a doctor's office to see a palliative care clinician, you're gonna have a scheduler, you're gonna have an MA room you, maybe even a nurse be involved in that, and then eventually that clinician's gonna come in and you're gonna have a chunk of time with that clinician. When we're going into people's homes, we're the scheduler, we're the MA, we're doing the vital signs, we're doing all the phone calls, we're doing all the documentation, and we're in that person's living room for an hour, usually. That's a totally different care model and payment model. But I think we're still saving money by doing that. And it's not just because we don't have enough hands, And I guess I wanted to point all those levels out because as we look at a main care benefit, I worry a little bit that there's just such a variation from case to case. I mean, certainly I have consults where I'm going in and we know before we even go in, it's gonna be a hospice referral. And it's a one-time and I'm back out and that's it. But I've got patients I've been following for 4 years that maybe were previously on hospice, graduated from hospice, now I'm following them, and then I'm getting them back onto hospice now. That's a totally different benefit for them over time. And I don't think, because there wasn't palliative care previously, we never really thought about that. I mean, we talk a lot about an exit strategy was mentioned earlier, but sometimes an exit strategy from hospice should include palliative care. It always should, actually. And that's just something else to kind of point out to you guys.
I'm sorry, I just want to make one comment, because I see Kathy Amsted in the back, and if I fail to mention this, she will,
I scared him.
minded and I really was speaking about the person power issue in palliative medicine as we know it right now, which is basically, by and large, provider-based, okay? Not necessarily saying that's the best model. A huge challenge, if we build interdisciplinary teams the way we all aspire to, a huge challenge is the number of social workers and the number of social workers who are skilled and, both they have the background in medical social work and they have the desire to do this type of work in palliative medicine. And while I don't know if the benefit will eventually parallel that of hospice, where we have, chaplains and spiritual support, I thought a very powerful argument was made this morning about the importance of spiritual issues. I think maybe others would disagree with me, but I think many times the issues, the spiritual issues sometimes come to the forefront just as much, if not more, in palliative medicine than in hospice. Should I just quote unquote check out, and sign up for hospice? I mean, there are many folks have a huge challenges that they have to overcome in terms of their own spiritual background or religious faith and so forth. So I'm sorry, I just had to get that in there because I know Kathy will beat me up afterwards if I left that out.
Yeah, I'll just say, I think, the goal of a more flexible payment model is never to be exactly the right for that one patient. It's an average, it's an average based on assumptions. And so there is why I say it's a remaining issue is there will be variability. And I think from a main care perspective, where I am right now is thinking, using the term from the previous speaker this morning, we want to create broad brushes. We want to allow for the flexibility. I think initially, when you roll models like these out, you may not get it quite right the first time. So I think, I feel like there's a lot of going for this in the sense that I think there's limited cost issues, considering the cost savings associated with palliative care. So the goal would be to build assumptions that we think will work, and then again, measure and monitor things like hospice lengths of stay, which you would expect to go up. I would expect to go up. And then the whole system, and to build the continuum. And I say that in a way that we've heard loud and clear that it's not helpful when payers have eligibility cliffs that disrupt care in such a way that makes it, as far as the family and the person, just a nightmare. And for us, honestly, for ourselves to administer those programs. So I think we're really trying to think about how do you create pathways for eligibility and services that don't feel or act like cliffs, and people can move back and forth.
Vanessa, and then would you?
Olivia, I was wondering, you said that you're still in the development stage. I'm wondering, do you have like a timeline roughly?
I don't have a timeline right this moment, but we do think we will have a timeline soon. But I'm not able to say right now what our timeline is. have a very good proposal, I think, in our hands, and so we're just trying to work through the process, but you will definitely hear when there's a timeline. The LD did not have a timeline, so it's still a high priority. We have, a full-time staff person.
What's the stage after development?
Implementation. So there's a few stages. There's a stakeholder process around rates that's actually legislated as well. So develop this, what does the service look like? And then we have a process where we actually put forward what the proposed rate model looks like, and we seek public comment, and we respond to those comments. Then we finalize a rate, and then we go through rulemaking, which is the state process for rulemaking. It takes about 4 months, includes public comment. Simultaneously, we are seeking federal approval. Sometimes we seek federal approval first if we're concerned that we've gone too far out of what's allowable or not. And then we are also building our claim system in the meantime, so that it can actually work. So it always takes longer than we would hope it would.
A lot of work.
Yes. But other states have done it. We're not the first state. I think there's over 8 states that have, again, depending how they're defining palliative care, different types of palliative care benefits.
Yeah, and well, I'll go to Melanie next, but I also just want to pull up for you that there is a really neat website through Yale that is palliative care law and policy, and so you can click on the state and see any relevant, having a little trouble with the Mac, I've never used it before. There you can see all the bills that relate to palliative care, the state that they are, and you can do it in any state in the nation. And I just Googled palliative care interactive map, but it's from Yale.
Can you scroll it back down to the top,
I
please?
can, and I do have this link for you on the resource page that I'm gonna hand out. Melanie?
Sure, so that was part one of my two-part question. And my second part of my question, main care, you said there's some federal attention in what we're doing. So is there an opportunity to sort of backtrack a little bit on the hospice benefit as well? Because, the benefit from private payers is anywhere from 60 to 70% of what we get from, care. So is there a way out of the gate that, what we're doing in main care, and if it goes to the federal level and more than 8 states jump on board, is there a way to sort of engage those private payers like up front so that we don't end up with the same situation with, the Anthems and Cignas and Harvard Pilgrims where they're paying us 60% of what we can, get for this population? I'm just curious if there's any of that kind of integrated dialogue going on at your level.
Well, I'll set up a conversation that's, I think you have maybe stronger feelings about it, so we one of the ways that this has come into the conversation in Maine is around what was the primary care first model out of CMMI that included a seriously ill population component that was scrapped. I think some people had invested in pursuing that or preparing for that. And so Maine is participating in that. And so we have put forward to the federal government, CMS, Medicare, around we'd like you to consider whatever we develop as part of maybe something you do, since you didn't do the serious ill populations component of this previous program. And I think federal government has been open to hearing about replacement models. Again, it doesn't get to hospice, but I think they're open to other innovation in this area. But I know there's been other advocacy around the end of that approach and whether you all are continuing conversations to try to push for something else federally too.
Yeah, we were an organization that was pretty heavily invested in trying to do SIP. Just for those of you who are unfamiliar with it, it was at a 50,000-foot view. It was designed to really take patients who the federal government actually, they actually have talk about data. We never see this stuff, and they actually have, some sort of crazy supercomputer. They actually have really good actuarial analysis on the Medicare patients, so they know, right? They're never going to reach out because it's like the third rail of, of the world is, declaring a patient, it's got a, 6-month prognosis of, 50% death. But the reality is, they know, they can identify those patients, and they also know what the projected spend is gonna be. So the idea was to take these folks, and most of them are really poorly connected to primary care, because they're in a cycle, where they, go something like hospital admission, skilled nursing home, oh, I'll see that patient in, well, before they even get back there, they're back in the emergency room, wash, rinse, repeat, you know what I mean, that type of cycle. So the idea was to figure out how to get these folks better connected to primary care, or in the cases where their trajectory and their goals were consonant with hospice, to get them enrolled in hospice earlier. I'll say that I have some, when I looked at the model, particularly serving a large rural population, I wasn't that optimistic we were gonna get these folks reconnected to primary care. I mean, the primary care system is super stressed and super broken right now. I mean, and most of these patients, it's not like they didn't have an opportunity to bump into some primary care doctors along the line. They're all super sick. They got pain, they got other problems that make them almost impossible to manage in a traditional primary care environment. And so I'm a little, I feel like this is a population, we need different models rather than burdening the primary care. I think many of these patients, we need, home-based primary care. We need dedicated teams who actually know how to actually take care of these people. They are willing to get in their damn car and go see them. You know what I mean? I think that's the solution for many of these folks, rather than assuming that with some sort of an intervention that we're going to connect people. It's I'll put it this way: any help in the space would be great. And I don't want to sound like Debbie Downer here, but I'm just saying that I have concerns about trying to overburden the primary care system.
Yes, I think it's really just about, I just say put your ideas forward, and I don't think there's an answer. Like, I don't think there's a one direction.
I was just wondering, in the model that you're working towards, how much virtual visits will be able to be a part of that model?
Yeah, well, Main Care actually has had one of the most progressive telehealth programs or policies since pre-pandemic. Many years ago, we established parity. We allow virtual visits to replace face-to-face visits in nearly every aspect, and have for years with the same pay. So absolutely, virtual care would maintain that status in this model. I think the questions we were just discussing today is, we hear a lot about the importance of the home visit, but then when you put into policy a requirement for a home visit,
That's the problem.
that's the problem, right? So,
Yes, ma'am.
yeah, so that's the problem. Everyone thinks it's great, but if you require it, then what? So, yeah.
That's
What are your thoughts?
exactly where I was heading. To be in home care, you have to do those face-to-face visits, yet we know that many visits can be done virtually after we establish a relationship, or after we see what the environment is going on. There's a lot we could do virtually. The second piece is that I was able to listen in on the advancing of the ACP bill to allow social workers to be able to do advanced care planning and to be able to be paid for that on a federal level. So will we be as liberal in this model in Maine to be able to have our disciplines be able to do more things that they're capable of doing and are doing, but may not be paid for that?
Yeah, I don't know that specific bill, but in general, if scope of practice supports it, that's generally how we operate. I'd actually think that we would allow that. I imagine we would allow social workers to bill advanced care planning now if they were within a physician group. And then I think that part of this whole conversation is where does the palliative care team sit, and where is this going to be anchored, sort of. But that's good to call to our attention. We'll look it up to make sure.
It's quite active, actually, as a bill. It was really quite interesting to listen to. So it would be interesting to parallel some of that. And if they make it or not on a federal level, as Maine goes, so goes the nation. So may we do it here.
One last question, yes.
Just on this theme of the interdisciplinary team, I wanted to highlight a population of patients that I think we see a lot in the home-based program. Our referrals are not heavy on oncology, but we see so many folks with dementia.
Oh, yes.
And I feel like we're seeing the tip of the iceberg, and it's such a population of people and families who become rapidly lost to primary care. that need intensive, really usually social work and care management and nursing support, and some nurse practitioners, and we love to do that, but I think that is going to be, such a tidal wave for us in the state, and to meet it, this conversation just feels so critical to me about paying for the interdisciplinary team to be able to help people age at home even with cognitive changes is just.
And the lack of caregivers,
Yes.
basic care, the families
Yes.
are dying here, trying to do this job. And I think what we talked about in the listening session, and I think it was in the listening session, where, relying on family members who have to actually figure out how to go to work or go back to work, but they've been years taking care of their loved ones. That is really a serious problem.
It's a minor, quick point, just for you guys to know with main care, that one of the biggest things that we have to do is figure out the referral to home health thing. Like, I'm seeing a patient all the time for multiple years, I can't refer them to home health. If they haven't seen their PCP in 90 days, I actually have to get the person who's homebound into their PCP or have a televisit in order for them to come home health. That's dumb. We gotta fix that.
So I just want to thank our panelists today. You did an amazing job. Thank you for raising some exciting new things happening and some great questions. And thanks to all of you for your interest and passion. We do have a resource sheet. I'll leave it here on the corner of the table. And I believe we're due back in the main room to hear about the results of the palliative care survey.